This is Cassandra Sciortino from the University of California, Berkeley. Today, she is going to be presenting Natality and Neonatal Intensive Care, Reflections on Caregiving, Birth, and the Womb. So thank you so much, Cassandra, and take it away.
Hello, Anna. A quick introduction for myself as well. I teach through the UC Berkeley Extension Art and Design program. I'm an adjunct, and I also teach at Diablo Valley College. This is my first encounter with actually bringing together a topic that I've spent a lot of time discussing with Anna since she began working on natality back in 2010. And it was just kind of in its infancy. And I was very excited because at the time that she spoke to me about this, I was busy, engaged in a life which I felt was very much separate from academics, which was volunteering as a neonatal intensive care baby cuddler, which I'll talk about in a moment. So naturally, I've had a lot of appreciation for motherhood, for birth, but also for everything that informs a relationship to our others, to infants, to our brothers and sisters, our community, in relation to a maternal frame. These are thoughts that we talked about in 2010. So when this conference began to unfold back, I think late spring, and she was all by herself filtering through papers, and she told me it's getting to be really big. And it seems like it's going to be 3 days, so there is room for me. So I'm not a specialist in birth studies. This is my first foray into trying to speak about and think through my experiences in neonatal intensive care. So I have a few slides to share with you, but hopefully I can switch between myself and my shared slides here. And I'm going to try to share right now, make sure I don't accidentally show something other than what I planned here. So I'd like to give a quick background. My work is, I'm also a musician. I'm a classically trained harpist. I've played the flute as a very young girl. It was my first instrument. And I'm have about 13, 14 years of serious training in Gregorian chant and medieval music. And I sing as the solo cantor for the National Shrine of St. Francis, dominantly Gregorian chant music. Which is monophonic and does not have a wide tonal range and is meant to move the listener to a space that is as detached from earthly concerns as possible, and create a sense of calm, meditative calm, like a lot of other world traditions of music. Now, so my work at the intersection of music, care, and caregiving began during a 2-year CRESS research fellowship at the Kusta Institute in Florence, where I encountered the Casa dei Bambini at the historic Ospedale degli Innocenti. Existing well within the old hospital and unknown, except I stumbled upon it, to tourists and even to my colleagues at the Kusta Institute. They knew of the famous facade, but not the active Little Casa dei Bambini, which means house of babies in Italian, within. Once I discovered this space as a young woman who loves babies and had felt rather disconnected from that part of myself as a researcher at the Kusta Institute, I was able to become a volunteer every night. And I volunteered during the course of my fellowship after my research, walked, it was only a block and a half from the Institute, conveniently. And I would hold babies who were at the Casa dei Bambini. These were babies that had been separated from their families, often awaiting adoption or recovering from emergency placement. There was no screening of me. It's a totally separate story of how I ended up there and how I came to be trusted, but it was all very quick and magical. And I was trained by the Italian caretakers there, dominantly women, but it's several men, how to hold, feed, and look after babies that had gone through traumatic ruptures in separations from their caregivers, severe situations of abuse, abandonment, and sometimes simply this liminal space of waiting to be returned to a parent who was in therapy or working through a legal issue. This early caregiving experience gave me caused me to develop a method of working with my voice and body to enlarge it. Because what happened was there were more babies than there were volunteers. And I found when I was holding one child sitting on the floor of this little Casa dei Bambini singing a lullaby, usually not even with real words because I was remembering Celtic melodies but didn't know the words. I would sing in my own more or less crude Celtic word shapes, rocking a baby. And I learned that if I set that baby down and continued to sing, the baby would maintain an association with me through song. But if I stopped singing, it would feel a rupture. And so I was able to develop bonds through sound and holding, and then take my physical body away, but preserve the immaterial vibration sound waves of my voice to continue reaching that child and pick up another. So in a way, sound allowed me to duplicate, triple, and quadruple my body. Upon returning to the, and there's a name for this that I will talk about in a moment, but I'd like to talk about this moment of moving between spaces. First, say this most simple process of taking a baby out of my arms and placing it near me is a kind of threshold. It's a kind of movement between states. And this will be a theme that my talk will pick up repeatedly. Upon returning to the United States, I began volunteering at the neonatal intensive care unit at Oakland Children's Hospital, which is itself an interesting discovery because when I left the orphanage in Florence, I don't typically cry much, and I loved the Kunsthistorisches Institute and all my art history research, but I couldn't imagine ever finding anything like the orphanage within this space here. You have to see this central door and imagine walking through it one night and just stumbling upon, actually rather illegally, but I was lovingly received into this space and being welcomed into it. How could that ever happen anywhere else? It seemed completely impossible. But there was a man, the director of the one of two directors of the CASA, who stood on this very threshold and said to me, "Never forget what you found here, and you will find it again." And he was right. The proof taking its shape in ways from Elaine Scarry's wonderful claim in her book On Beauty and Being Just, that a property of beauty and brackets, and for me, the Ospedali and my experience there was the most beautiful place I'd ever found. According to Scarry, one property of beauty is that it brings copies of itself into being, or as she puts it, deeply beneficent momentum towards replication, suggesting that the desire to imitate or create beauty can be a positive force. In this case, of course, she was speaking about the replication by artists copying other works of art. Before I move forward, here's a view. This is not a photograph I took. It's a promotional, not really a promotional photograph. It comes out of a brochure from the Ospedali degli Innocenti, from UNICEF Innocenti, which is one of two institutions within the historical hospital that are actively looking and researching for the care of children worldwide. But there's an active small space for abandoned children in trauma and so forth. And here is a view that's in one of their brochures. And I recognize that window and the radiator with much fond memories. Now, returning myself as a young researcher back to California and to the San Francisco Bay Area, I was on the BART train, looked out the window, lamenting my seemingly impossible to replace orphanage, only to see a duplicate or replication of the very same medallion that is outside the Ospedali degli Innocenti by Andrea della Robbia. Here, a variety of swaddled infants in varying degrees of wrap, and of course embodying every child in that wrap and the need for every child to be held and swaddled and nurtured. A magnificent image, of course. So it felt like I was having a Fellini moment as I saw this outside a BART train window. BART is the name of our rapid transit system here in the Bay Area. And here's a view of what was then called the Oakland Children's Hospital, and left in the 1960s, and below the medallion, and here Florence on the right. So I promptly had to be there because the threshold encounter here with the director seemed to be coming true. Not that I thought of that then, it only came in retrospect. Within the hospital, there are numerous duplications of the swaddled bambino. There's a modern clock There are multiple mediocre plastic renditions, and of course, the beautiful terracotta on the exterior of what was the original entrance. Finally, there's a rather modern 1959 stained glass window in a chapel to all faiths, to be a meditative space of contemplation, holding for the families of children in the hospital. Here's a view of the hospital today. On its front side, quite modern, of course, but on the back side is still the old brick. I think it's due to be taken away entirely, but we're still in that liminal place where it exists. Now, unlike the orphanage in Florence, I was required to go through a very rigorous training to become a volunteer in the neonatal intensive care unit. So here is a view of that. And I spent about a year and 4 months at the hospital working in different departments with children under supervision until I'd earned enough hours and been sufficiently trained to go into the neonatal intensive care unit and become what's called a baby cuddler. So here's a view of that space. It includes metal cribs with cushioned mattresses, but it also includes more classic incubators. I don't know if I have a picture of that, which is what are more womb-like spaces, but there are many babies that are not, that one can actually physically hold and not simply reach through and touch. And I won't be talking much about the technological, the cyborg discussions of this space. It's not palatable to my experiences there, nor to my argument. But indeed, there's a lot of technology that's reconstructing womb-like experiences, but never separated from the human element, at least in my experience. Here's a photograph of myself about, let's see, maybe 12, I guess this was maybe 13 or 14 years in. By then I'd become a baby cuddler mentor. So I was someone who trained new baby cuddlers and shared my techniques and methods. One of which I will talk about now, which I'm happy to say, was written into the baby cuddler manual, but I can't take credit for discovering it. It's well known in studies of music therapy in infants, but that material, that scholarship is slow to get traction across the United States and in Europe in hospitals. Some hospitals are more advanced and others not. Here's a view of some volunteers holding infants. This is not at Oakland Children's Hospital, or today called UCSF Bienhof, but just to give you a sense of what this looks like. Very small babies. Babies are usually swaddled, held up against the chest, the heartbeat being the first point of stimulation, and sometimes more than enough for these small babies. I'm just going to show some slides. I'm not going to read them, but to just document the therapeutic benefit for infants of having someone in the role of cuddler is well documented. And here are some of those benefits. Again, I won't read them out. And then the training and role of volunteers. So here's just for those of you curious, it's a rigorous process. Here are some of the key elements of that training. Now, what I'd like to focus on more in this talk, and which is, I think, well suited to the topic of this magnificent conference, and I enjoyed very much the talks yesterday, and it was very inspiring. I wanted to start rewriting my talk. So I'm going to talk about entrainment to start with. Entrainment in the context of the NICU refers to the synchronization of an infant's physiological rhythms, such as heart rate, breathing, or sucking, with external rhythmic stimuli. In music therapy for premature or medically fragile infants, entrainment helps stabilize vital signs, promote neurological development, support emotional regulation by aligning breath, heartbeat, in particular, with another stimuli. So entrainment musically, how does that work? So I'm a singer, and of course, it's now, especially when I first began, there was very little about music therapy. But now there is clear warnings. Music is very dangerous for micro preemie babies. You wouldn't want to just suddenly start strumming a harp or a guitar or playing a flute among, particularly in a neonatal intensive care unit. That said, it's very common for a volunteer to hum or murmur. It's part of our training. We're trained to begin with a recognition that sometimes the only stimulus an infant needs for is to be placed against our beating heart. And it's been shown that babies' regulatory systems can sometimes align to even to the heartbeat as the infant did inside the in utero. But a volunteer is also trained to pay close attention and to determine if there's is it appropriate to start maybe moving the baby a bit, maybe singing. And so, in some cases, as particularly with older babies that were dealing with traumatic health issues, it became very clear that singing softly, relative, I'm a soprano, high voice, which is known to also babies can process that more easily than low pitches when they're very young. Um, that singing Gregorian chant, which is what I know well, it could be Indian chant, ragas, Middle Eastern forms of chant, or Chinese pentatonic scales. But and these all share many modal similarities. These traditional forms of music that are not terribly complex. And so by singing and beginning to match my Gregorian chant to the breath of the baby, to the heartbeat of the baby, I created an entrainment. Now, I'm not a musical therapist, so I wasn't seeking to change the baby in any way. I wasn't seeking to guide the baby's breath towards something better or guide the baby to learn how to suck on a pacifier to cultivate suckling in general. That's well beyond the scope of what I was doing. But I was creating a bond. I was using those rhythms to create a sense of a connection to my body. Um, so the see if I move. So I'd like to talk now about I for the NICU as a transitional place for sustained entrainment and crib reentry. So I'll just go back to an image. I just want you to imagine here this woman here. I'm not sure if she's a mother or a volunteer, but imagine she's a volunteer and she's been holding this baby, singing to this baby's heartbeat and breath, and the baby's in a lot of pain. Say it's a heart baby, it's dealing with a lot of issues. And you've been gently singing and creating that bond for a couple hours. And maybe the baby's come in and out of sleep and it's woken up. And once again, it's rhythm, your voice, your singing is matching its physical bodily rhythms. What I found, and the hardest thing about being a volunteer, is when I did have to leave. I mean, at that time, volunteers did put the babies back into the cribs themselves. That has changed in some cases now. But I would be responsible for transitioning to standing position, cords allowing, state of the baby allowing. And in most cases, I could. And bring that baby back. You see where this pink gate is dropped. Lay that baby back down into this soft but now non-human environment, at least temporarily. And how do I um, reduce the rupture, the sense of separation, both for myself, knowing that I would leave, and also the baby? Well, I found that by continuing to sing and slowly and gradually removing my arms, wrapping, swaddling the baby, placing my hand on the baby's chest, and continuing to stay with their rhythms, continuing to entrain with the child, that slowly I could remove my hand entirely, just have my hand hovering over the baby's chest. Typically, if they were laying on their backs, which that was almost in most cases the proper way. And then the baby would, it seemed, and this is anecdotal because but it was something observed by others and something I did end up training other volunteers to do, not so much necessarily singing Gregorian chant, but humming, or finding a way to attune or in train, that it greatly reduced the shock of separation. And I speculate, and I would love to welcome thoughts from this beautiful panel of specialists, that maybe my body remained with the baby insofar as I had entrained to the baby's rhythms, which is in a way a reversal of the womb, where the baby's rhythms are moving with a mother, and the mother is the owner of the rhythms until birth. Um, So this is an important point in the neonatal intensive care unit. I have some quotes here that I will just share. Here's, I think, my this is the entrainment quote. Um, there's also just a lot of documentation, a lot of it happening short, about 5 to 10 years after I began my work. There that the value of music therapy for infants, quite a lot. It's been documented. It's better live than recorded. Even a mother's recorded voice is inferior to the live experience. And the best voice of all is the mother's, and then the father's, and any, of course, that a baby has heard in utero. And then barring any of those, which in my case, I was holding abandoned babies going whose mothers are in drug rehabilitation, maybe the baby's going through withdrawals, maybe the mother surrendered the child altogether. I mean, typically the babies I held were ones that didn't have a stable support system, if any at all. So I wanted to mention a few other points. One is that the spectral similarity and therapeutic elements of voice itself. The effectiveness of voice-based entrainment may be partly explained by what we call spectral similarity, the overlap between the acoustic features of live vocal sound and the human auditory system's evolutionary tuning. Ruth Stanley, 2014, notes that the traditional healing music systems, including ancient chant scales across culture, closely resemble the formant structures of human speech. Schaefer et al. Demonstrate that slow monophonic music is better tolerated in emotionally deregulated states and aligns well with natural vocal contours. There's been further studies I can't talk about, which observes how many possible scales there actually could be across globally, and how remarkably alike different scales are, even though they seem different to us relative to the possibilities of intervals in singing. An interval is some la la la. That's an interval. That there are scales based on those intervals, and there aren't that many varieties, and they share enough similarities to be rather striking. And studies show links in these early scale formations, not so much later complex classical music or jazz music and so forth, but these early forms relate to our vocalizations, and that may be why they have such a calming effect on the infant, along with being monophonic, soft, maybe muffled in some cases in recalling the womb. So I have a number of points I don't have time to talk about, but I'm working on, which is this idea of a threshold practice. A threshold practice, that is, refers to an intentional action or form of care that supports or accompanies a person or group through a transitional phase or liminal state. It's often used in philosophy, ritual theory, and healthcare to describe practices that are enacted at or around critical boundaries such as birth, death, and major illness, grief, or identity change. It takes place in between moments, acknowledges ambiguity or transformation, may involve nonverbal, sensory, or symbolic elements. It does not attempt to fix or solve, but hold space, guide attention, or provide coherence. These elements were absolutely true in my experience with holding babies. The less I thought about the baby's outcome, the less I wondered what was wrong with the baby. I didn't always know the details. The less I worried about whether the baby was in pain, the less I thought about what the baby was needing, and the more I emptied myself to be in tuned and entrained with the baby in every possible way, the more effective the therapy. So it's this work to fully detach oneself from wanting to know, wanting to fix, wanting to cure, but to remain deeply empathic. It rather reminds me a little bit of some of the lessons, say, in the Heart Sutra, but that's perhaps for another talk, or something written by the Carmelites, spiritual work of John of the Cross. There's some other interesting connections that could be developed in a different talk. Now, I would like to just make one point in that, along with that, these babies that I worked with were not only in a transitional place or a liminal place, which is the neonatal intensive care unit. It's between, for many babies, birth and actually being outside the uterus, because so much of the interior is trying to recreate that space. That's open to some debate, but what isn't open to debate, I don't think, is that there is, for the babies I held, many of them, a permanent or indefinite separation from their primary kinship network. So that is another form of liminality. That liminality affects nurses, as well as the infants, the sense of wondering what will happen next. And I experienced in times when I would held a baby and I sang chant, when a nurse would say, for example, one case sat down next to me and said, "Please keep singing. Yesterday, one of the babies right here died." And I feel as though there's nothing that's been done to acknowledge it. It's been very clinical, and I was very bonded. Contrary to what you sometimes read in the literature, my observation of nurses were they were highly engaged and got quite bonded with the babies they cared for. So the presence of singing in this, it could be, in this old form of chanting, whatever origin it may come from, in these particularly not particularly wide range scales, is calming. And for this nurse, it created a ritual space, a symbolic transition from life to death. Now, at the last point I'd like to make, I'm pretty sure I'm getting very short on time here, is in recent years, I've become very involved, again, stumbled into it with work in cremations, another liminal space. More and more Western world and Asia are are choosing cremation over burial. And in the cremation space, these it's been noted that the closest loved ones typically can get, if they wish to be present at all, is to watch the cremation through a window or on a video monitor. That's a pretty sophisticated option. Not all cremation facilities have this. None of the cremation facilities where I sing and play harp have such an option. But I, again, rather stumbled into a situation where a family had heard me sing in a different context and wanted me with their son who had died in the room where they pressed the button of the incinerator. So I discovered that if I bring my harp and my voice now and the practices of entrainment into an incinerator, beside an incinerator where there is a body in a coffin, and make it into and use entrainment now, not so, in maybe matching breath, but more using the harp and the modes to match mood and spirit, and maybe silence is enough. Sometimes just the image of a harp and virtually no playing is powerful, just like a heartbeat, and no singing is for a baby. Sometimes, in this case, these little children wanted to be a part of the therapy. They wanted to make the music for the deceased who was engulfed in flames now and being transformed. They wanted to be a part of that sound bath that was filling this otherwise industrial space and cold space. And it creates, I mean, I'm sure those of you here could give me so much more to hold on to and anchor my experience to theoretically. But at the most basic level, this is another kind of entrainment, another kind of, for me, um, a moment of transition, and I like to call it a threshold because it brings something more positive to both the case of holding a baby that may be dying, a palliative care baby, or an environment such as this, because a threshold has a sense of ascent into my ear versus liminal, which is so ambiguous and fuzzy. And an image that came to me, and I would say it's a very poetic image and not at all academic, but it recurs, is I feel like in moments where I'm placed with a particularly acutely ill baby and I have a particularly salient sense of a connection, as well as in these cremation spaces, that I'm sitting on a silver lining between heaven and earth. Thank you.
That was beautiful, Cassandra. Thank you so much.